This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Like all the previous speakers from this morning, I'm going to mention that in 1995, when Ken Hillman published his paper, I was still in high school. So I'm a bit of a rapid response novice, I have to say, in comparison to the other speakers from today. So when I first decided to make the move to Australia, I was told that life in Australia revolves around beaches. And of course, even when I was working in New South Wales, we have the Between the Flags system. And that's a very important system that, again, reflects the life around beaches in Australia. I have to say, like Alex from this morning, when I first heard about the rapid response system, I was quite skeptical. I wasn't a rapid response worshipper, I have to say. Certainly in Ireland, that was a system that was not in existence when I was training. But over the years, I've changed my mind. I've realized the importance of this system, particularly in our healthcare system, and also very important for the rest of healthcare systems around the world. So I think, like all important questions or answers in life, you can break it down to 3 questions. I'm a very simple person. I'm not, I'm not very brainy, so I just make everything as simple as possible. Does it happen? And looking at the audience from today, I suspect we all know that this is the case, so I don't need to put forward my argument for that. How often does it happen with regards to med teams and end-of-life care? Whether we really need to take notice of this. And then I thought, maybe I'll just be a bit adventurous and I put a 4th question in. What can we do about it? But I believe the next few speakers would cover that topic in this session. So I'm just going to simplify it to my little 3 questions. So we're all familiar with these cards. We probably have it attached to our lanyards, and like Alex already had alluded to, colors are very important. It makes us pay attention to what we're doing. And in the hospital that I'm working at the moment, we also collect data on these other criteria, which suggests that people are worried on the ward, and they can call a med call if needs be. So this is a common observation chart that we see. I used to work in New South Wales, and we have the Between the Flags observation charts. So you might have a patient who is a bit tachypneic, you might decide you stick in on non-invasive and see if they respond to that. If you have a patient whose SATs are a bit low, you might give them a bit of oxygen. If you're a very wealthy department, you may even give them high-flow nasal prongs. If that doesn't work, then you might decide to intubate them. Oh, sorry, that's actually not to go have a beer, but intubate them and bring them to intensive care. Or if their blood pressure is a bit low, you might stick a central line in and run them on some noradrenaline. So that's the stuff that we're very good at doing. As intensivists, we're trained to do that. We can do any of these procedures probably under like 5-10 minutes. And that's why I decided I wanted to do intensive care a number of years ago. So like any good researcher or person who needs to give a speech in public, I have to look up what is actually on the internet, because that's really important, and it appeals to the Gen Y population, which I'm sure there's some of you here in the room today as well. So I found this when I typed in dying, and this came up as one of the top 10 hits on Google, and it says what to expect and how to respond to the natural dying process. And it talks about how physicians and nurses involved in end-of-life care know that certain symptoms are usually associated with the body shutting down. So apparently, according to this website, we are very good at diagnosing the dying process. And I love debunking, looking at things on the internet and go like, what's that? Like, that doesn't make sense. That's a load of rubbish. So if you bear with me, I'm just going to put a next few slides on what's actually on the website. So it talks about excessive fatigue and sleep, which, if this patient was in a hospital, would mean an altered GCS. And how to respond is to permit sleep and stop waking the patient up and doing regular neuro-ops assessment. I actually think that's not true. So I think that what they really need is a MEC call. And then there's another symptom of mental confusion and disorientation. Again, that's altered neurological state. And how to respond is to remain calm and reassuring. That's not really true, because what we really need is a MEC call. And I could go on forever. Labored breathing, how that would translate on the observation chart would be tachypnea. And how you should respond is to sit the patient up, be supportive. That's not really true, because what they really need is a MEC call. Changes in urination. We get very excited with low urine output. We try to do stuff, give them Lasix, give them fluid, whatever. And I don't agree with how to respond in this situation, because what they really need is a MEC call. So when I was doing my research paper with Anthony, Darryl had published his paper on the role of the medical emergency team in end-of-life care. So this was in 2012. And they looked at 7 hospitals across 3 countries, Canada, Australia, and Sweden. And it was a 1-month prospective audit looking at 512 patients and 652 MEC calls. And what they found was a third of the MEC calls were associated with limitation of medical therapy. These calls were more likely to occur out of hours. And the patients who had pre-existing limitations on medical therapy was about 20%. And after the med team had seen the patient, this increased up to 10.8%. So a total about 31% of the med team were involved in limitations of medical therapy. The patients were also likely to be older. For those who receive limitations of medical treatment orders, they were more likely to be medical admissions, and they were less likely to be from home. So then, when I was completing my training, I was working with this brilliant guy, slightly odd, and I said I wanted to do a project in end-of-life care and intensive care. And for those of you who've met Anthony Delaney, he would scratch his beard, he would scratch his head, and he kept scratching, and it's like, I'm never going to get to doing a project with him. And then a couple of months later, he comes back to me and says, I know what you should do. You should do something on medical emergency teams and end-of-life care. I was like, okay, right. Don't really know much about the medical emergency teams, considering that I was working in a hospital that did not have a medical emergency team at that time. It's like, well, whatever it takes to just get my SICM project ticked off. So our question was, how often did medical emergency teams deliver end-of-life interventions, and how common were these interventions in comparison to the other interventions that med teams did when they went to call? So the introduction, obviously we see the quite similar introductions across all the papers that have been published on med, and the role of the med team essentially is to reduce the incidence of cardiac arrests, adverse events, and hospital mortality, and more importantly, from our point of view, unplanned hospital ICU admissions, and in terms of our bed status. We scrolled through 2,000 plus references through PubMed and Embase. And then from that, we looked at, we managed to get about 131 manuscripts, which we manually went through. Applying those inclusion criteria and the validity criteria, we came up with 35 studies in our systematic review. You can see that majority of the hospitals, about 22 of them, were tertiary hospitals from all over the world. A couple of them were university hospitals, a couple of teaching hospitals, and 1 or 2 mixed hospitals. And four of the papers did not publish what type of hospitals they were. There was a mixed bag of retrospective, prospective cohort studies, observational studies, and you can see that only 1 study met the validity criteria. And we had about 12 studies which define a priori methods in their studies. And what we did then was we highlighted the studies which actually reported MET interventions and limitation of medical therapy, and then we grouped them in order of priority priorities in terms of what interventions they did, and we've slotted in limitations of medical treatment with that. And so you can see that for all the 16, we found 16 studies which fit that criteria, and we could see that limitation of medical treatment was quite commonly performed in some of these studies. Particularly in these 2 studies down here, we found that intubation was less commonly performed than actually dealing with limitations of medical treatment. And I guess that's important because we're always looking for doctors or trainees, or they come up to us and say we don't have any airway experience. So that's important because we need to think about, what are we training our registrars to do? Because apart from just doing airway stuff, they need to be able to deal with this situation on the ward when they go for a med call. So just the rest of the data, we found that between 9 to 57% of the patients got transferred to a higher level care. So higher level care could mean CCU or ICU or HDU. And we found that not all the studies reported their DNR rate before MET calls, but it ranged from between 6 to 34%. Interestingly, none of the studies, even though they reported end-of-life intervention, actually referred the patient to palliative care services. And after the MET team were involved with the MET call, we found that limitations of medical treatment orders were instituted between 1.7 to 30.8%. We also looked at the composition of the MET team, and like Darryl Jones had stated earlier, majority of the people involved in the MET team are medically led, and we found the same in the systematic review, that majority of them were intensive care registrars or fellows, and a small proportion of them had intensive care specialists as the leading person for the MET team. So that was the conclusion to our study, was that limitation of medical therapy by MET team was very common, and that we need to be prepared to train our doctors who attend these MET calls. And I think the next speaker will be talking about training in medical emergency teams. In comparison to our local data at Epworth Hospital, our DNR, or limitation of medical treatment rates pre and post MET, are quite small, and that's because we are primarily a surgical unit. A lot of the hospitals that were included in our study were mixed, and some of them were more medical than surgical units. And I'm sure that applies to different units depending on the different skill mix, the case mix that you have. So I found this paper by Andrew Hilton, Darryl Jones, and Ronaldo, looking at, and he has a really nice diagram looking at when, as intensive care specialists or intensivists, when we actually encounter patients who have been chronically ill when they come into hospital, and we only encounter them at the point of acute deterioration. Occasionally, or sometimes, depending on the structure in your hospital, we may meet these patients at the time of admission. Sometimes we get phone calls from the emergency department saying, I have this patient that we think that you should know about, but we're going to send them to the ward. So that may be the first time you've heard about the patient, not necessarily mean that you have to do something about it. I find those calls quite annoying because I'm not quite sure whether I should see the patient or just wait for them to deteriorate on the ward. And it talks about how we can project clinical deterioration based on the history and their comorbidities. And they have a really nice diagram looking at when an 80-year-old comes to the intensive care or gets referred to intensive care. And I'm sure all of us have been tried to sold the good 80. I have a really good 80-year-old that I want you to take because they're really, really good. They can play golf, they can do this and that. And what I love to do is just cut out this diagram and then laminate it, stick it on my lanyard. And every time I get referred a patient, and just show them this diagram. So I might change this to red because I think blue looks quite benign. I think a red line would be very nice. And that we need to start talking about diagnosing dying, which Andrew has quite nicely, has a couple of paragraphs talking about how we don't recognize dying because we are able to implement interventions such as intensive care treatment that actually prolongs the process of dying. They also talk about the advantages and disadvantages of the medical emergency teams being involved in managing end-of-life care on the ward. And that perhaps one of the main issues, apart from a resource perspective, is that we generally have come across conflict in dealing with end-of-life care, particularly with the parent team. And a lot of these deteriorations tend to happen in the middle of the night where the parent team cannot be contacted. And this, the conflict issue is reflected in this paper. There was a survey done in Italy which discussed that majority of the teams, the medical emergency team participants felt that there was a lot of conflict involved in dealing with end-of-life issues on the ward when they attend a MEC call, particularly with the primary team, particularly as well with the family involved as well. And that kind of raises questions as to how do we look after our team members whom we sent out on these medical emergency calls on a day-to-day basis. This is a document that was published by the Australian Commission on Safety and Quality, and there's a section there that recognizes the fact that we are now involved in managing the dying on the ward as part of our responsibility in the as a medical emergency team, and that we do a lot of the med stuff that we do revolves around end-of-life care. And some of the issues or difficulties that have been highlighted, including the fact that like Michael DeVita mentioned, it doesn't really matter who's doing it, but somebody should be doing it. And I think it's a really good thing that the intensive care team are doing it, because we are well placed in a position to actually discuss some of these issues, outsourcing them. And they also found that clinicians report it's often much easier to continue treatment than to talk with patients and families about the end of life. And communication is very important with families when it comes to managing this in a very productive and effective way. So some of the feedback, obviously, that's come about with producing a document like this is from different specialties or from different members of the team, include that that the MET team is now become an end-of-life team, and this is now deviating from the role of intensive care. I wouldn't say it's deviating. I just think that our role as intensive care specialists is evolving rather than deviating. Like the previous speakers have alluded to, that it is a huge resource consumption, but it hasn't been shown to actually impact on our patient outcome. The fact that we get pulled away from our ward rounds, and some specialties, some doctors obviously feel that we're sorting things out for other teams, and as Michael DeVita pointed out, well, it should be a patient-centered care. It's not about us. It's not about you. It's about the patient. And these are the other kind of comments from other people, and that we've made it really difficult to diagnose or recognize dying on the wards, and the med team is now seen as a support or a second opinion to support the diagnosis of dying. So in summary, medical emergency teams and end-of-life care is pretty common. It's as common as some of the commonly trained common interventions that we're trained to do, like intubation. We should embrace this as part of our role. I certainly do not think that this is a deviation from our role. It's an evolution of our role. We should be better prepared, and I hope that the next few speakers will talk about training and resource allocation. And there are systems in place. We are very fortunate in Australia that we have systems in place to acknowledge that this is an issue and how we can move on from that. And I think Angus Carter last year at BCC, you said that we should really keep calm and just own it. This is our job, and we should do it well.